We know, of course, inevitably that most policing of family violence historically and in the present has to be reactive after the damage has been done. So in the reactive policing model, not only in domestic violence, but in general, the violence occurs. Someone may call the police, it may not be the victim. Police may respond, although in different jurisdictions, there's different levels of seriousness of reaction to domestic violence compared with stranger violence. So police may respond, they may arrest, but in general, there is little punishment and little by way of deterrence for domestic violence offenders. What we do know from our research in the United Kingdom is that most offenders do not repeat, at least to the extent that repeat calls are made to the police. But of course, some cases do repeat, and harm, and perhaps high harm, may be repeated. What we would like to discuss today is a different approach, a more proactive policing approach, in which police rely much more on the information they already hold about domestic violence offending in their jurisdictions. So we would recommend that police look first at their own records of their own prior cases and identify those abusers which are committing the highest harm. We would recommend what we call a focused deterrence approach, which I'll speak a little bit more of in a moment. But the objective would be to reduce future harm by means of more effective targeting of the highest harm offenders, because not all domestic violence is equal in its impact. Next slide, please. Next slide. Thank you. What do we know about the pattern of domestic violence? I can report on research that we've conducted in the United Kingdom and elsewhere. And what we find wherever we look is that, in fact, a surprisingly small percentage of domestic violence offenders are responsible for an extremely high proportion of the harm. And the graphic that you can see here actually demonstrates this very well. This was a study carried out in a jurisdiction in the south of England, and it is representative actually of what has been found in several other places as well, in fact, wherever we have looked. And that is that the highest harm, 3% of offenders, were responsible for 90% of the total harm that had been endured by domestic violence victims. So this pattern is a very important one to remember, because it allows police to look at the problem in a much more creative way by using certain predictors that we can discuss in a moment, and follow up on precisely those few high harm people by using strategies of focused deterrence, which entail actually focusing, as we say, on those high harm offenders, identifying them, talking to them, letting them know that they will be subject to additional scrutiny, that a stance of zero tolerance has been decided about their criminal activities, and that any future offending will result in swift, certain, and probably severe consequences for them. We need to focus on these small number of people, and we can do so even more effectively by the police partnering with community groups to provide support services for those offenders whose problems underpin their violent behavior. This might relate to substance abuse or mental health problems and so on. And there has been quite a lot of very innovative work conducted to demonstrate the effectiveness of this approach. So we would recommend that there should be a focus on these high harm offenders, and that proactive policing, focusing on them, should constitute at least 50% of all police resourcing in this area. Next slide, please. So how do we do this predicting of high harm? If there has been a prior police contact and police hold records, then we can locate those people, bearing in mind that most offenders have no repeat calls to the police. Most repeaters are low harm, that the highest harm offenders are few in number. So what we indicate from our research is that regular police contact is more likely to prevent high harm than no contact. And so how will we go about locating and targeting what you might call the worst of the bad? And the first step is, as I mentioned earlier, to look at records already held by the police on domestic violence offenders, to assign to each offender the sum of all the offenses they have been involved in, and then to compute the total harm that they have been responsible for in their offending behavior. And the most important thing is to rank order these suspects by that level of harm, to find the highest ranking 3% or so, a manageable number, who are responsible for the greatest harm. Next slide, please. So the studies which have underpinned what I have proposed here come mainly from the United States and the United Kingdom. They have limitations in their usefulness because in those studies, the cases were rank ordered not by harm, but by frequency of calls relating to those individuals. And frequency, as we know, doesn't always correspond to the extent of harm that they're responsible for. For that, we need a crime harm metric that Professor Sherman can talk to you about. But obviously, this approach only works with known suspects. So what happens if we don't know who they are? And we do know that about 50% of high harm cases, at least in the United Kingdom, come from offenders who've never come to police attention before. So I'm going to hand it over to Professor Sherman now to talk about what happens when you don't have records that you can use for this purpose. Thank you.
Thank you, Professor Strang. Some years ago, I opened the newspapers and discovered that a professor down the hall from me at my university in Philadelphia, at the University of Pennsylvania, had just been arrested for murdering his wife. He had no prior criminal record. She was leaving him. He was in a bad state of mental health. But it's quite typical for the studies of domestic murder and attempted murder to find that the offender has had no prior contact with the police. So while we highly recommend a strategy of targeting the repeat offenders or anybody with a record of high harm for domestic abuse, has gone to prison for domestic abuse, Somebody got out after 6 months of prison for domestic abuse in northern England 10 years ago, immediately murdered a police officer and killed his girlfriend's new partner. He had not been tracked coming out of prison. Nobody identified him as an important and high risk of high harm offender. But we can certainly prevent some domestic murders with the offenders we know about. It's the unknown offenders that is the challenge, because the studies in Milwaukee and Melbourne, in the area outside London in England, and across all of England, all of Denmark, Western Australia, maybe it's not true in the Latin American countries, but we can't say that because we know. The fact is it's unknown, because to my knowledge, there has been no study of domestic abuser murderers in any Latin American country that has estimated the percentage of them that were already known to the police. If we start with the assumption that you will have at least some people who are not known to the police who are committing domestic homicide, and especially under the mental health stress of COVID and lockdown, what I think we can say is that it's very important to say the risk factor that has the best predictor in all of these studies, and it's the prior suicide attempts or threats to commit suicide by these people, which were often reported after they had killed their partner. But the police need ways to find out in advance who is threatening or has attempted to commit suicide, and to look at those people in particular, not with a focused deterrence, not with a "we're watching you" kind of approach that worked very well with domestic abusers who are not mentally depressed, who are not suicidally inclined, but who are still very violent. So that's a different category. The category we talk about now is how to find the people in the population who are suicidal and may well kill their spouses, their partners, as my colleague at the university did. But those people are spread throughout the population, and to find them is like doing what the next slide shows, which is to find the needle in the haystack. Next slide, please, for the needle in the haystack. That's what we have to find. Who are those needles out there across all of Montevideo, across all of Buenos Aires, or Santiago, or any city in the South Cone? You will have people walking around looking perfectly normal, doing their jobs. Just this week in London, we had a man go to work in a grocery store, and everything was fine. And he went home and he stabbed 2 children to death under the age of 3, and then killed himself, or tried to kill himself. Obviously, he was in need of mental health support. The question is, how would we have known that? And in that particular case, we still won't have the review of the deaths for some time. But in many cases, what we can find, as we see in the next slide, we can find that there are risk factors associated with domestic homicide, like unemployment or drug use or alcohol abuse. But those factors are very common throughout the population. They are hay. They don't tell us about the needles in the haystack. So the reason to focus on suicide is because it's very rare in the population. If somebody is threatening to commit suicide or has attempted to commit suicide, that is part of a tiny fraction of the population compared to the vast sea of unemployed people, or people who drink too much, or people who are using drugs. These risk factors that are common in the numerator of the cases where killings happen make it too hard to predict which is the needle. But if you start focusing on the suicidal ones, you will still have lots of hay, but you'll have much less. And if you can take people who have already attempted to commit suicide, then as the next slide shows, what you may have is the ability to try to prevent homicide by using the same techniques that have been tested and found effective in preventing suicide. So what the National Academy of Sciences in Washington, D.C. reported last year is that repeat attempts of suicide are preventable because attempted suicide is treatable. We have 2 clinical trials using something called cognitive behavioral therapy, in which the psychologist repeatedly talks with the offender, with the patient who is suffering from depression, suffering from suicidal ideation, suicidal tendencies. The treatment for this gets the patient to think differently about their outlook, about hope, about the realities that they have a good family, a good job, a good reason to live, and to stop this spiral of depression. And this approach, which has been tested in many other contexts, has specifically been found to reduce attempted suicide for the second time in 60% of the cases. And because of this powerful effect on repeated attempts to commit suicide, it's not theoretically unreasonable to suggest that this same treatment could prevent domestic homicide. Now, what we don't know is whether, first of all, the attempt to commit suicide or the threat to commit suicide actually predicts femicide or killing of children in families or other members of the family. Does that record of suicidal behavior predict future homicidal behavior in Latin American countries? We don't know that. And we also don't know whether in Latin American countries, the use of cognitive behavioral therapy can be effective in reducing repeat suicide attempts, nor do we know whether if we reduce the repeated suicide attempts, can that reduce the risk of femicide or of family murder, indeed anywhere in the world, because even in the UK, even in the US, this idea is still in developmental phase. I have been talking to the highest levels of government in the UK about this and working with a number of police forces. But because the privacy barriers between healthcare on the one hand and policing on the other hand have this great big concrete barrier in between them, we have seen refusal to cooperate between mental health and police with respect to sharing information about who might be more at risk and who might be savable, who might be saved by having cognitive behavioral therapy. We don't know these things, but when it's a question of knowledge, that's a problem we can solve. We can know this if we try to find out by using the research about these cases of the most extreme domestic violence, which is committed by people the police do not have any information about until somebody's dead or there has been a horrible attempted murder. So if we can go to the next slide, please, Barbara. I want to summarize what we have said to you today by drawing this contrast between the domestic offenders that the police know about, who they already know, on the one side, on the left, and on the right, to think about who don't we know about? Who are these needles in the haystack who we have to find and take a very different approach to around their mental health as opposed to around their failure to be deterred by the police. So to police the known offenders, we have good evidence to show, number one, we can identify the highest harm offenders, and we can then additionally reduce the harm that they cause by classic police practices that would emphasize the theory of deterrence, going back to Beccaria in 1763. By digitizing all family violence cases, for each offense by each offender, you multiply the offense by some measure of how serious it is. An attempt to kill is very different from slapping somebody, very different from twisting somebody's arm, There are many gradations of violence, and in the United Kingdom, we have sentencing guidelines. In Uruguay, we have worked with the police to use maximum versus minimum sentences and halfway in between. However it's done, if the harm metric multiplies the seriousness of each offense times the number of those offense categories, and then adds it all up, for each offender, we can get a rank order from the offender with the highest harm total for the last 5 years down to the lowest. And then by just taking the 3% at the top, targeting them, visiting them with focused deterrence, with discussions about how they cannot get away with it, and that there will be extra efforts to make sure that everybody in their family is okay. The evidence shows in general this does not increase the risk to the victims. It reduces future evidence of harm. Ideally, you would test that in Latin America with the addition of hospital information or other medical information to discover whether there has been harm without it being reported to the police. So that's for the known offenders. Over on your right, when we look at the unknown suspects, even the police records on suicide attempts that the police respond to is a good source of information for predicting domestic homicide based on prior suicide attempts. Most digital record systems, I'm certain that Chile, for example, and Uruguay can do this. If you track every suicide attempt in your database for the last 5 years and look at who those people are, possibly cross-check it against history of family violence, but even if there is no history of family violence, you can check up on them in COVID to see how they're doing and to see whether the COVID is making their mental health worse. And if it is, to provide as an offer, not a punishment, but as a service, free cognitive behavioral therapy. And if you don't have the psychologists in Latin America who can do that, it can be done even on Skype or Zoom to psychologists in Spain, where they would be able to practice CBT. This all needs to be tested. And so I can only conclude, as we say for everything about COVID, that what we need to do is to test, test, and test. Thank you very much. We'll be happy to answer questions at the end of the panel. Thank you.